Good morning, ladies and gentlemen. May I take this opportunity to greet all of you on behalf of the Indians from Bangalore. We appreciate your conference in a great manner. Incidentally, Fifth World Dental Conference is being held at Barcelona, Spain, and in fact I was invited to participate in this program. Unfortunately, due to the circumstances and as a result of the COVID-19, I am unable to travel to Barcelona, and I am here with presenting my small message of the decision making and treatment planning in periodontics. Incidentally, the periodontal diseases have been ubiquitous. No man is free from it, no race is free from it. It is like a scourge upon mankind. There are over 700 species of microorganisms present in the body, in our mouth. And incidentally, this particular periodontal diseases have been unchallenged and been present in every corner of the world, wherever it is. And today we are still finding in the crossroads to have a solution for the treatment procedures. I am afraid that to tell you it is going to be a long journey of periodontal treatment and decision making, and therefore I am trying to give a small anecdote of procedures that we are going to follow in the management of periodontal diseases. As you know, that periodontal diseases are also correlated with systemic conditions also. Many situations like rheumatoid arthritis, or it could be even heart diseases, or it could be even cerebrovascular strokes, or it could be in the form of possibly of endocrinal origin, all have repercussions on periodontal tissues. There's a two-way side effect, one from the systemic to the oral changes, and from oral changes to the systemic effects, and therefore we have to be very much aware of all the changes that are taking place. So friends, we move to the second part of the story, when I'm going to talk to you about the periodontal decision making. Now, as you know, in the past, several people have talked over for the several, about 1.5 months or 2 months, and they have all been telling the various methods of periodontal treatment and implant therapy and all those things. Incidentally, we have been listening to a lot of methodology of treating by patients with scaling, root planing, even by flap surgeries, or by grafts, or by doing soft tissue therapies, which could be in the form of grafts, or pedicle grafts, or it could be of autografts or anything like that, or it could be implants also, or it could be in the form of a restitution of the dental occlusion, or improve the aesthetics. So there are different ways of doing dental treatment and periodontal treatment also. So what I'm going to do is I'm going to talk to you in a big overview of all these things in one way or the other. And incidentally, I will try to be a little faster because I've got a number of slides, and I will try to warp up faster and faster so that we will be able to gain the knowledge to some larger extent. Well, this is my dental clinic. Incidentally, this is at Hanuman Nagar. And this is my layout. This is my clinical situations. And unfortunately or fortunately, we have learned a lot of periodontology from different places, from different people, from different schools. And incidentally, periodontology has come a long way in India and other countries as well. So there's a book also on history of dental specialty, milestones, and the maturation of periodontology in the world, by Robert Rudy. Another book, beautiful book on non-surgical control of periodontal diseases, comprehensive handbook by Levi. Incidentally, these are some of the books which I love to talk to you all, because dentistry does not mean by putting a knife in the patient's mouth every time. Ultimately, what is important is, as we get the compliance, if we do a good dental treatment, if we do a good scaling, a root planing or anything like that, non-surgical approach, we will be certainly successful and keep the natural teeth for a longer period of time. Some eminent people in the field of periodontology in the world. Okay. There are several eminent pioneers in the periodontology, which includes Quaker, John Riggs, we called it Riggs disease those days, Willoughby, Miller, William Younger, Robert Koch, of course, you know all them very famously because the Koch postulates, and William Hunter, William Kirkland, who designed the Kirkland knives, Bernier, Irving Glickman, the father of periodontology then, okay? And these are some of the beautiful books which I learned through my days. And this is none other than Offenbecker, who is supposed to be the father of periodontal medicine, whom I met way back in 1987 at the World Workshop, the American Academy of Periodontology in Seattle, Washington. Well, periodontal diseases are associated with different ailments, different aspects. It could be right from the form of periodontal changes, gingival changes in architecture, the position of the tooth, because there will be diastema, there could be bleeding, there could be abscess, there could be furcation involvements, and whatnot. All these are the landmarks with changes associated with the attachment loss, tooth mobility, root exposure, and mobility, and all those things. And has got different added influence upon respiratory system, upon osteoporosis, on the endocrine systems, cardiovascular systems, and other parts of the body as well, including, of course, reproductive system, eclampsia, low birth weight babies, and all those things. I want my patients to be like this, so beautiful teeth, so beautiful gingiva. Believe it or not, this person, a lady, had come to my dental school in KLE Dental College in Bangalore. You can see there was hardly any calculus in the mouth. There's hardly any gingival inflammation. There's only a little broken area in relation to the left upper central incisor. Apart from that, I did not find anything in the patient's mouth. Imagine if every patient has got like this, there will be no dentist, there will be no periodontist also. Okay, so I love to see this patient time and again, and this was the greatest thing that I saw in my lifetime. Anytime in my clinical practice of over 45 years. This was at KLE Dental College, Bangalore. Now, what the hell happens when periodontal diseases takes place is there is loss of alveolar bone. You will notice that there is also a breakdown of periodontal tissues, periodontal fibers. There's furcation involvement, and all those things which you are very well knowing. This man is, of course, supposed to be a very important person in the field of periodontology, and he has written the books in dental biochemistry and all. Incidentally, he happens to be one of the famous persons around. Now, well, the determination and assessment of the patient risk factors, just now I was talking to you, age, diabetes, smoking, cardiovascular diseases, and all those things can have its impression upon the periodontal disease as well. Well, periodontal probing is one of the best method of understanding the breakdown of periodontal tissues. And bleeding on probing is the first and foremost sign of the periodontal disease. And of course, associated with trauma from occlusion, you will find that there could be various changes that could occur. And apart from that, Fremitus test would be of great help in understanding whether there is any low or high freno attachment, right? And just come back to the position. Next. Yeah. So as I was telling you, ultimately our objective is to make sure that we have not only
good gingiva, but also sufficient width of the attached gingiva also, so that we will try to enable the patient to have good oral hygiene. If there is a high fremeral stress, there is gingival pull, or there is a low width of the attached gingiva, high width, so naturally that will affect the oral hygiene and oral cleansing also. So what I want to suggest now is how to identify all these aspects is a very important aspect, which we try to understand by doing a proper recording of periodontal tissues. And I'm going to skip a lot of slides because of time paucity, and I'm going to jump over to the treatment planning itself. Now, when we do a treatment planning, it's important that we have to have a proper recordings. Unfortunately or fortunately, I was telling you in the previous talk also, we failed to do a proper recording, case recording, or what you call as medical records. A successful periodontist is one who knows the patient has what he has got, what the patient needs, and when and how to execute the treatment. It's a very important thing. Patient will come to you with all sorts of problems. We should know what the patient has got in the patient's mouth. We should also know what the patient needs. Ultimately, you can't do what patient does not want. You should ask the patient, what is your need? Why have you come to the clinic? And ultimately, that will be very much helpful to understanding to reach to the patient's goal and how to execute the treatment. You can tell the pathway, look, these are the different steps. You have to come 5 times or 10 times or 15 times so that you will be able to give a proper work to the patient. So as I was telling you, history recording plays a very important role. Unfortunately or fortunately, we don't do that properly. Of course, we have to do also the various aspects, like including the consent. 99% of our dental clinics do not use the consent forms. And that is a very important thing, because this is a very important thing which is helpful even in the medical legal aspects also. If there is an accident or if there is anything like that, we can produce the pictures or we can produce the radiographs, we can try to show the models, and all those things could be of great help. So consent is a very important aspect which we should take before we do any treatment. So data collection, which includes clinical examination, probing, mobility, radiographic examination, and we have to do the charting system also. As you know, as I'm telling you, pre-operative charting system or post-operative charting systems, all these things are very much helpful to understand the facial aspect or the lingual aspect of the incisors or the molars or whatever it is. All these things should be recorded. And our diagnosis is also very important. When we do the diagnosis, it could be in the form of different differential diagnosis, whether it's gingivitis or periodontitis, and there are different types of classification of periodontitis, which I will not go into details of how to talk all these things. According to Armitage, you have got different types of periodontitis, adult periodontitis, you have got aggressive periodontitis, in that also you've got localized aggressive, generalized aggressive, and what the ultimate objective is to treat the patients. Treatment can be done in two aspects. One by a general dentist, one by a people like me, periodontists. The oral prophylaxis, root planing, repetitive root planing, all this can be done by not only a dentist but also by a hygienist. In fact, in other countries, patient only comes for surgical aspects in periodontics to the periodontologist, but otherwise the remaining aspect is all done by hygienists. Oral prophylaxis, root planing, repetitive root planing, all this can be done by a hygienist. And let me tell you, this is the preliminary treatment which is very much important, and that will go a long way in patient's hygiene and maintenance also, which you can do it by either manual or by ultrasonic instrumentation. And oral hygiene instruction and reevaluation all can be done by your dentist, hygienist, or somewhere like that. Another very important thing which I would like to tell you is when you select a patient for periodontal surgery. Let me tell you, if you have 100 patients coming to your clinic with periodontal pockets, not all the patients with periodontal pockets will be a good candidate for periodontal surgery. This is a very important slogan which I will tell to the people. Unless and until you do a good root planing, unless and until you have taught the hygiene to the patient, unless and until you do a revaluation of your patient after 6 weeks or 4 weeks, then only you can plan your treatment schedule for surgery. Not before that. You cannot venture all of a sudden to put a knife in the patient's mouth. And all these things depends upon the type of pocket also. The lateral walls of pocket, which is soft or firm, whether it's a depth of pocket, which is about 4, 5 millimeters or 8 millimeters or 10 millimeters, whether there's furcation involvements, whether there's osseous defects like 1 wall, 2 wall, 3 wall pockets, there could be a crater, ledge, all these things could be a way. What could you plan either by doing a gingivectomy or doing a flap surgery or doing a mucogingival surgeries? What would you like to select is the question. That's where the decision making comes. You know, it could be a resective procedures also in the bone. It could be in the form of osteoplasty or osteectomy, or it could be in the form of osseous regenerative surgeries, or it could be the form of grafts, like using bone graft materials. Okay, so ultimately we start with the initial therapy, then we come to a surgical therapy, and then we come to the maintenance part also. In surgical therapy, you can talk anything. It could be a GTR, it could be a flap designs, regenerative procedures. As I was telling you, you could use a membrane with a graft, or it could be used membrane for treatment of osseous defects. And it could be different types of soft tissue procedures also by gingival augmentation using free gingival grafts or connective tissue grafts or coronal advanced flaps. So, ladies and gentlemen, let me not tell you too much in details. I'm going to start with the aspects of how do we go ahead, in these aspects. How do you manage? Number one, as I was telling you, there are different phases in periodontal treatment. You've got preliminary phase, you've got a non-surgical phase, you've got a surgical phase, a restorative phase, and then finally a maintenance phase also. As I was telling you, you need an informed consent of your patients before you start the treatment. Incidentally, all these things you do, charting and all those things. And then after evaluation, you try to examine the patients, and we try to do non-surgical therapy by doing scaling and root planing procedures. It could be in the form of manual or it could be ultrasonic. In those days, manual root planing was one of the biggest procedures which we had to undertake before we learned for periodontal surgeries. Believe it or not, just working for 4 teeth or 6 teeth, we used to work for 3 hours. Doing with a beautiful, subgingival scalers, braces curettes, we used to do the root planing procedures, and it used to take about 2.5 to 3 hours to treat for 4 or 6 teeth. And we had to do the beautiful way. My professor, Dr. Devrath, used to say, the root of the tooth should look like the tusk of an elephant. That's what I still remember those days. Should be shining beautifully, without any speck of calculus on the surface of root, and it should look like a tusk of an elephant. And that's what it meant, those days, without any presence of, endotoxins on the surface of the root. Because believe it or not, if you retain some substances like endotoxins on the surface of root, there will be no reattachment, there will be no regeneration also. So mechanical instrumentation in ultrasonic debridement, even sometimes you use a supragingival irrigation device also, spray chlorhexidine in the pocket environment, or use subgingival irrigation. That all will reduce the microbial flora. The whole objective of doing scaling and root planing is to reduce the microbial load. And these gram-negative anaerobic microorganisms are the potent cause for periodontal diseases. Unless and until you relieve them, you remove them, you will not be able to achieve success. So all these are the ways by means of which you will do irrigation by supragingival or subgingival irrigation, use a local drug delivery, use of antibiotics, use of host response. All these things could be of great help in reducing the microbial load. Of course, I will not talk in much detail on all these things because I understand the time factor, and I have not much to tell you on this aspect because you know all these things. You can even use a supragingival irrigation. And incidentally, our friend was there, Dr. Addy, who was supposed to be a very pioneer in the field of chlorhexidine and all. Incidentally, he was the one who launched the irrigation with chlorhexidine, supposed to be a very important tool for reducing the microbial load. And that could be helpful for, you can imagine, they can reduce the inflammation from 6.5 to 54%, if you do a good irrigation and do a good root planing and remove the plaque. This is Martin Addy from UK, supposed to be a very important person in non-surgical periodontics. You can imagine how the spray of, the solution, the chemicals can come on the surface of the teeth by jet. Well, local drug delivery, I will not talk much on these things also, but I will just tell you the doxycycline hyclate, which was supposed to be in the form of Atridox, can be of great use. Incidentally, it is available in the form of a drug called as Periostat in USA. It's available in the form of 20 milligram strength. And this doxycycline hyclate plays a very important role in chemically modulating the inflammation. These are chemically modulated tetracyclines, which are supposed to inhibit the breakdown of collagen. Now, ultimately, the damage to the collagen is the whole cause for the periodontal diseases. So, if you can reduce the collagenase activity by, using this hyclate, that could be of great help. Incidentally, you can give this 20 milligrams twice a day for a period of 6 months or 4 months also. So this chemical agent will be helpful to reduce the breakdown of collagen as far as possible. Now, there are different types of substances which can be used in the form of periochip, or it could be found in the form of Atridox, could be in the form of metronidazole, dentamycin, and all these are the agents which can be used. Incidentally, as I was telling you, there are 600 species of microorganisms in your mouth. 1 ml of saliva has 5 billion microorganisms. The whole population of the world is in 1 ml of saliva. You can imagine how densely is our mouth infected with microorganisms. So no wonder the periodontal diseases are all attributed to some of these harmful species of organisms. Actinomyces, Actobacillus, Actomycosum comitans, or it could be in the form of Porphyromonas gingivalis, or it could be in the form of Capnocytophaga, or these are the organisms which can be of cause for the periodontal disease. So this is Atridox. You can see the doxycycline hyclate, which could be of great importance. Well, here is the one which I was talking to you some time back, Periostat Collagenase pharmaceuticals, supposed to be a collagenase inhibitor. This is a group of periodontologists at GDC Bombay who are teachers and who have been training the students in the last few years. It was taken in Bombay for a workshop. Periodontal diseases, how it affects the dirty organisms. This is Actinobacillus actinomycin comitans, Porphyromonas gingivalis, spirochetes, Porphyrogingivalis. You can see the snake-like organisms. This is supposed to be the spirochetes. It's a great microbiologist, Professor Lakshman Samaranayaka, who is a very good friend of mine, who was the one person who spoke. The first program was by him only, incidentally, and is a great person in our country and in Hong Kong. Incidentally, this is my friend, Dr. Hazare from Nagpur. So all the science of periodontics is based upon pocket reduction procedures, pocket elimination procedures, periodontal regenerative procedures, and periodontal resective procedures. If this much you know everything about periodontics. Okay? It's like telling a person in pathology, if you know cysts, if you know tumors, if you know inflammation, you know everything about pathology. Something like that. If you know pocket reduction procedures, if you know pocket elimination procedure, if you know regenerative procedures, if you know resective procedures, you know everything about periodontology. And nothing is remaining. Okay? But whole science is in this aspect only. You can see how the nasty inflammation is there, how much damage has taken place here due to abscess. You can see how the damage has taken place due to the bone loss. Okay, horizontal type of bone loss. Okay, you can see the angular type of bone loss which is taking place here. Yes, so vertical or angular type of bone loss. Here you can see there's a a sort of crater formation here, like okay. Once again, a reverse architecture. You can see how the nasty damage has taken place here. furcation involvements. Okay. So these are all things which you have to treat. To see the amount of information that is here. Okay. Pendulous, this Silman clefts here, presence of, swollen gingiva, all these things. If you treat them, we can see absolutely everything is gone away. Yes? But there's still some redundant reading and points and all that there, of course. Yeah. Once again, here is another situation. So here is a phrenectomy which we have done because there was a narrow width of the attached gingiva. There was high frenal attachment, and that's why there was a big diastema also. So there's also breakdown of bone. There's an angular defect which we did the filling with the bone grafts, and we have covered it and covered with a dressing. Right? Once again, you can see the measuring pocket depths here. Once again, grafts have been done. Okay, sutures in placed. Okay, and that's it. Here is a tissue where the pupil denudation of the root. You can see the localized gingival recession, and the graft has been placed. Sutures have been placed, covered, and this is to be afterwards. You can see how the teeth are here, of course. Okay, it's a nasty tooth, broken down. So ultimately, what we want to do is a surgical treatment. In the field of resective surgeries, we could be anything. Treat the regenerative procedures, correct the osseous programs, or treat the abscess, or it could be restoring the patient's mouth with prosthetics and cosmetic approaches. All this could be procedures which, according to 1996 World Workshop of, okay, and corrective surgeries, what you do, you try to correct, soft tissue as well as the hard tissue. You can do a gingivectomy by correcting them, soft tissue, ledges and wedges, all those things, open a flap surgery and all these things. Sometimes you have to do a both hard and soft tissue combination. Okay, sometimes you do a plasty or osteotomy and all these things. And you do a flap access, different type of access is there, incisions are there, which I would not like to talk to you on all these aspects. So the whole aspect of pocket treatment is, all these things in the health, parabolic, it could be done in different ways, or it could be in the form of altered or parabolic or mismatch, all these things. Now, Ocean Bean, the great man who designed the chisel, I don't know whether you have heard of Ocean Bean chisels, supposed to be used to do the treatment for osteotomy and osteoplasty. He told the gingival tissues are dominating criteria in establishing osseous contours. Let me tell you, it is the osseous breakdown that causes the change in the gingival tissues also, because the gingiva has to rest upon the bone. And if the bone is already lost, you will not be able to get a proper contour. So that is very important. So if we have to restore the gingival architecture, we have to also improve the osseous contour. That is also very important, according to Ocean Bean. Now, there are different aspects. Definitive, it could be a sort of a positive or a normal parabolic form, or it could be compromised, where we would like to improve the osseous topography, which could need removal of the bone, okay, by either osteoplasty or osteotomy, so that we will have an improvement of the tooth. Now, resective surgery is most predictable and maintainable pocket reduction procedure. It's the only therapy that significantly reduces the destructive bacterial colonies. Let me tell you, I have reminded earlier also, it's a bacteria which are responsible for the periodontal breakdown. So if you try to reduce the bacterial accumulation by doing a good root treatment, by doing a good pocket elimination procedure, by improving the bony architecture, you are trying to reduce the accumulation of the bacteria, according to Mombili, Robertson, and other people. Pocket elimination with osseous surgery results in fewer bleeding sites, the greatest pocket reduction with the least chances of recurrence. Alteration of the subgingival microflora from gram-negative to gram-positive. That's what I want. No, I don't want these microorganisms which are gram-negative, which are anaerobic in nature, which are supposed to be very nasty ones, which are motile in nature. I don't want them. I want good positive, gram-positive organisms, which could be in the form of streptococci or cephalococci or something like that, which could be very much useful to us. So, could be a shallow infrabony pocket, furcation involvement, or it could be in the form of non-supporting alveolar bone. So all these residual osseous defects and all these things can be treated by different approaches. We use a transgingival probing method, to understand the osseous topography, bony pockets, bony defects, and all those things. Use also radiographs, also we do. We design a full thickness flap, an inverse bevel thickness flap, or a scalloping, do a good debridement. Think of the attached gingiva, see of the palatal vault. So position of the tooth also in the arch also very important, because if a tooth is tilted, then you have to influence upon the bone morphology also to a larger extent. So usually when you do an osteoplasty, you are removing the non-supporting alveolar bone. You do a grooving, fence tuning, okay? You do a radicular blending, and all these things are done in such a way that you try to improve the bony architecture. The end point is the enhancement of flap replacement and adaptation. If you don't do a good replacement, you don't adapt the flap to the approximate areas, you will not be able to adapt. If you don't adapt, then you will be losing, there will be gaping. So suturing is also a very important aspect. To have a good suturing, you need to adapt the flap ends properly. That's a very important aspect. That's why I was talking to someone who are undergoing suturing procedures. I was telling them that you must not do the tight suturing also, and because sometimes it will tear also. If you do a suturing which is inadequate also, if there's gaping, then periodontal disease can recur also. That's what I was trying to tell someone there, the other side. And when you do an ostectomy, you do a removing of the supporting alveolar bone. And there's attachment loss also taking place. So our purpose of doing ostectomy is to have sufficient support, improve the aesthetic concerns, and also make sure that you follow the norms. I will not talk on much of all these things. Let me go on to the next aspect, because I have a lot of things to talk. Regenerative procedures. Let me talk a little about it. What do you mean by regenerative procedures? You are using certain materials or substances which can help in increasing the bone height. Now, variety of bone grafts, including autografts, allografts, xenografts, and alloplasts, are supposed to be playing a very important role in the development, in the regeneration of the periodontal tissues and the bone. So here is again a lot of substances which you can see here, which can help in improvement. A growth factor, bone matrix, could be a minerals, it could be different ways. You can use a hip bone, marrow, and that could be of great help. Or it could be in the form of graftor. Alloderm also is used for soft tissue grafts, and emdogain, which can be used also on the root surface, and that can be helpful for regenerative procedures. Now, ultimately, regeneration means is defined as a reproduction or reconstruction of a lost or injured part in such a way that the architecture and the function of the lost or injured tissue are completely restored. Now, ultimately, our objective is to make sure that we bring back the normal architecture of the gingiva by improving the bone height. Unless we improve the bone height, the gingiva will not come to its normal position to a larger extent. We may not be successful 100%, but at least if we get about 4 millimeters of increase, probably that will be of great help. Whereas reattachment is defined as a regeneration of fibrous attachment to a root surface, surgically or mechanically deprived of periodontal ligament. And the third part of the story is new attachment. Now here, in new attachment, it is defined as formation of new cementum and new alveolar bone and embedding the new connective tissue fibers on the cementum and alveolar bone, which are previously damaged due to periodontal diseases. So we have different ways of doing all these things. Bone replacement grafts by osteogenesis, could be done, and that could be of great help. You have different types of graft materials. It could be autograft, isograft, homograft, allografts, heterografts, which is also called as xenografts. Now, as I was telling you, these are different ways by means of which you can try to do the bone regenerative procedures. Use of alloplastic grafts, HTR, bioceramics, tricalcium phosphate, hydroxyapatite, bioactive glasses, all these things can be done. And you can use the intraoral sites by using the extraction sockets, edentulous ridges, bone trifant from the jaws, and osseous coagulum. And extraoral sites, I was telling you about the iliac crest, which can be used for bone marrow removal. You have different ways: bone blend, cancellous bone, or it could be in the form of bone swaging technique, which can be used for periodontal grafting. I'm jumping from a few more slides. Don't mind. Now, ultimately, ultimately, our story is, after doing all these things, what happens? You put the concoction there, you give the sutures. Ultimately, this fate of bone grafts has to undergo various changes. There could be removal of this bone which you have already placed by what is called as, by doing osteoclastic activity, number one. That will be followed by the presence of newer osteoblastic activity will take place. So all this could help in remodeling. Ultimately, you will find there are following steps taking place: revascularization, reincorporation, replacement, and remodeling. So I will not go into details on all these things, but you will find that revascularization can take place as early as 2 weeks in the cancellous bone and about 2 months in the compact bone. Now, cortical areas. Anderson has shown the speed of vascularization is directly related to the degree of osteogenesis. The perivascular osteoblasts are a part and parcel of revascularization process, whether they are derived from the endothelium or from primary or primitive and mesenchyme. Revascularization also permits osteogenesis within grafts, and it may occur well with the host bone. Incidentally, I am a pathologist and a histologist as well, so my interest is more towards how the bone formation takes place. That's the whole story is. Incorporation signifies a union of new bone to the graft material or to the host bone by means of a cement line. This bonding at the cement line may be permanent one, where you will find there is a new osteogenesis taking place. Now, histochemical analysis have shown that cement line could be of mucoprotein in nature. Now, the second part of the story, I was telling you, replacement. There is a loss of this grafted bone, which you already taken place, as I was telling you, by osteoclastic activity. And you will find the resorption of the graft and substitution with a new bone taking place. The creeping replacement is a substitution of alternating waves of new bone for the graft bone, which has taken place. The third part of the story is remodeling. Well, as I was telling you, it's a gradual but a continuous effort or recontouring at the graft site with the new bone formation. This new bone is supposed to be associated with the formation of a framework of osteogenesis. Now, local tissue comprising of bone connective tissue in revascularization taking place, incorporation, replacement, and remodeling all taking place at the same time. Well, if you do a non-graft regenerative procedures, incidentally, you will find that sometimes if you do a good root process, root planing procedures, you will find that the root surfaces which are exposed exhibit certain pathological changes. There could be destruction of the sharpish fibers. You will find there's hypermineralization of the cementum. and penetration of the cementum, and in particular, I got delayed because of the lack of power in my computer. Replace it again. So we have different approaches for non-regenerative procedures, which could include, different ways by means of, using some chemical agents on the surface of root, or antibiotics on the surface of root, which can help in stimulation of the formation of new cementum, or it could be helpful in the enabling the rejoining of the cemental fibers to the root surface. So for that reason, we do root conditioning procedures, and we can use different methods also by using citric acid, or it could be in the form of phosphoric acid, fibronectin, tetracycline, EDTA, or sodium hypochlorite, which can be helpful to remove the what's called as the layer on the surface of the root, which can be helpful for improving the attachment. So that's how it is called. You can use even sodium deoxycholate, could be antiformin A, Cons factor, different ways which can be treated for the root surface, which can be helpful for to improve the attachment of the fibers to the root surface. Whole idea is make sure that you create an environment for improving the attachment of the to the root surface by the fibers. Now, soft tissue changes that could occur could be associated due to some medications like dilantin sodium therapy, or it could be due to non-inflammatory enlargement, or it could be as a result of orthodontic therapy, which could lead to enlargement of gingiva, and this overgrowth could be which will be very much anesthetic. At the same time, it will be difficulty for the patient to maintain good hygiene. So incidentally, we can do gingivectomy or remove the enlarged gingiva by scalpel or by use of laser. And all this can be useful to remove the infection and also same time improve the tissue environment so that the patient can improve the hygiene. You can imagine this is a story as a result of dilating hyperplasia, and you can see how you try to remove it and it becomes a beautiful one. And sometimes loss of interdental papilla could create problems. We call it as black triangle, and that could be one of the cause for interproximal foot trapment. At the same time, aesthetically displeasing, and interproximal contact area which will be visible, and you'll find there's a adequate bone support will also be not there. So improving the papilla or improving the bone support can also help to fill the interproximal space. So sometimes you do the surgical therapy with the help of, as we had talked earlier, with the use of some alloderm or some material, so that you can improve the architecture of the tissue also. So you can see the beautiful, palatial building, hotel at Las Vegas. Same way, you can improve the tissue architecture also, remove the root stump and try to put an implant there. So temporary, which has been given for some time. We've done a bone filling there. Okay. Graft has been put, and you put an implant subsequently. And afterwards, you restore it, and that becomes normal. You can see you cannot differentiate between this and the back tooth. Okay. So what is important is various techniques of guided tissue regeneration also has been done using bioresorbable or non-resorbable membranes, which we called as PTFR, okay? The polytetrafluoroethylene PTFE membranes, which are supposed to be once upon a time very useful in graft procedures, and that is supposed to be of great use in those days. But incidentally, these non-resorbable membranes had to be removed after 6 weeks. That was the drawback of these programs. Okay, and nowadays you have got bioabsorbable membranes also, collagen membranes and all that, which could be of great use. And unfortunately or fortunately, this is one of the important person who's responsible for the furcation involvements. Supposed to be dentist, supposed to be play a very, very important role in furcation areas and classification also. He has done a great job. So you can imagine if there's a furcation area, you will try to close it up using some membrane graft, and use also a PTFE membrane, close that wound, and then after, see, you can find out how changes take place after 1 week. You remove the membrane after 10 days, and then you can find a lot of changes taking place subsequently. So the membrane also gets exposed in for course of time. That becomes dangerous then. Okay, and then you will find the clot and regeneration of tissue all taking place in the course of time. Okay, so these are some of the membranes which can be used in those days, which we used to do it as a hard work to cover the root surface. Well, prognosis of GDR membrane therapy depends on the defect of morphology and also availability of the progenerator cells. Incidentally, what's important is we should get some growth factors also there, some regenerative cells also, which are supposed to be of great help in providing regenerational fibers and the bone as well as taking place. Of course, important is also the operator skill. Now, if the patient is the learner or the person who is doing the job, if he has not got sufficient skill or knowledge, it will be a problem. And most important, as I was telling you some time back, the compliance. If the patient is not compliant, he does not know what we are doing, so everything is going down the drain. So success or failure depends on that also. And of course, smoking. If a person smokes, you will find the membrane exposure takes place. So, smoking is again a harmful aspect in periodontal treatment. So as far as possible, patient should reduce the amount of smoking or avoid smoking to a larger extent. In a systematic review, membrane therapy showed limited value in treating defects, associated with periodontal diseases. As I was telling you, vortex membranes, PTFE membranes, you've got Resolute, Gesslac, okay, or it could be Vicryl for a periodontal mesh, Johnson & Johnson product also. So here you can see the bone grafts which have been done. You can see the coverage of the bone that is taking place here comparatively to other ones. And of course, use of loops in periodontal surgeries have been of great use. We talk of loops not only in conservative dentistry or endodontics, but also in periodontal surgeries. Many people don't use this. This is the great man, P.D. Miller, with whom we took a picture. He was his 73rd birthday, way back in 1987. And he is still a strong man doing a lot of job for, reconstructive gingival and periodontal surgeries, which have been of great use. Well, precision is the whole story now, which I'm going to talk to you. Could be due to so many reasons, bone dehiscence, could be malpositioning of the tooth, high frenulal attachment, or infection or inflammation. And all this could bring about varieties of changes. You can see the P.D. Miller classification. 1, 2, 3, 4, all varieties are there. Okay, and the whole idea was generation of coverage on the root surface by use of lateral pedicle grafts by Sullivan and Atkins, or it could be Langer and Langer subepithelial connect tissue grafts, or Vermilion by gingival extension procedures. And all these stories you will find that the sliding flap that was supposed to be a very important aspect, which was supposed to be playing a very important role in lateral pedicle grafts, which could be of great help in coverage of the root surface defects. You can see how the changes have taken place on the root surface following the lateral pedicle graft. Same way, you can see some more pictures here, which we have covered with the root surface. Okay. Once again, you can see variety of changes that have occurred, because of the graft coverage procedures. Of course, we don't use a direct periodontal dressing. We use a tin foil before, okay, and then cover it with the periodontal dressing, so that this acts as an intermediary, so that you can try to protect the tissue from irritation. So here is the story. That's how it's taking place. Of course, there's a loops. Now, what I'm going to talk to you is some more pre-operative and post-operative changes that take place. Sometimes we use 2 sittings, 3 sittings also to do all this job, harvesting the tissue from different areas, either from the palate or from the soft tissue areas. You can do it. And of course, here you find another picture with the help of people around. And you can see this is supposed to be a very important aspect, where you can see the variety of changes that take place, as a result of two-stage procedures, where you will try to cover it up with the graft. You can see the lateral premolar area, how the precision occurs. You do a incision on both the sides, okay, and then close the wound, and you will see how much is the coverage, okay, the difference. Similarly, you can do some more areas also. So here is where a pouch technique which we are doing, you will find, we are taking it from the palate, okay, and then we are trying to take this particular graft, put it up there, then cover it up, and you, for the time being, you give a small of retainer plate so that it will help in healing, and that's it. Okay. Here is again precision taking place where you can use alloderm. Okay, so you try to open up these areas, push your alloderm in between, and that's it. So alloderm is being pushed inside, okay, and then cover it up. So all these are the ways, techniques. You can imagine how you can change. You can see the enlargement as a result of orthodontic treatment, and subsequently to the removal of the enlargement taking place. So reconstructive therapy, which could include so many things. No, we can even do a mucosal procedure. You do a tooth exposure, crown exposure. You do a vestibular deepening. You do a papillary reconstruction. Okay, you do a ridge augmentation, ridge preservation. All these are the stories behind periodontal therapy also. Procedures benefit periodontal health through reconstruction of the lost and hard and soft tissues by preventing additional loss. And they also enhance the appearance of the patient. Sometimes you may have to improve the increase of clinical crowns. So you can imagine there's a short crown here, there's hardly anything visible. So you chop off the gingiva around that area and then increase the crown. Can you see this? Yeah. That's it. Same way here also, we have done the same thing. Sometimes you can see this particular tooth. No, there was hardly any crown structure here. So we had to remove it, some of the bone also, chop off the bone, and then improve the exposure of the crown, thereby so that we can visibly more improve the tissues. Well, periodontal aesthetics is another association of periodontal and multidisciplinary procedures, which help to establish the complement of teeth functionally and aesthetically. Ultimately, we talk of biologic principles, we talk of periodontal anatomy, relationship of bone and soft tissue regeneration in aesthetic zone and dental implants. All those things are very much essential. Now, I am trying to tell you where all things we can improve is not only in the margin of gingiva, but at the same time, you can also improve the anterior fractures or anything of the tooth. You can improve the jaw embrasures. You can improve the implant site preparations. You can improve the aesthetics also of the face, okay, by changing the smile and all those things. And of course, not forgetting your occlusion. That's a very important story. Occlusion can be improved. So synthetic relations can be improved so that you will be able to improve the longevity of the teeth, thereby by reducing the damage to the bone. Now, many times patient will come with occlusal wear and bruxism patterns. So aesthetic mock-ups have to be done, and how to do that particular aspect is a very important story. How much you can allow the occlusion to take place, how much you can restrict the occlusion to a larger extent, so the patient can have a proper, victory over the occlusion. The whole story is this. Now, ultimately, our objective for longevity of natural teeth is based upon a bilateral, distribution of the occlusal load. And if you don't distribute the occlusal load uniformly in all as many number of teeth as possible, you will be failing in your attempt to treat the patient. So the whole story of periodontics also depends upon occlusion, whether you replace it by substitution by orthodontic way or by orthodontic way or by doing an occlusal equilibration procedure. All the story depends on how you want to improve the occlusion and how long you would like to do this work, because occlusion treatment is not one day's job. It takes several months and years also. Sometimes you may have to use some therapy also, where you use some electrodes and all to improve the muscular activity of the temporomandibular joint activity and the muscles of mastication. All these things can be of improvement. So what is all things which are associated is a very much important story. I hope you know this lady, supposed to be a great lady who was supposed to be known for her smile, but she had no teeth in her mouth. So that's the story. A smile is a curve that sets everything straight. Okay, and ultimately, how we are trying to do the improvement of all these things is by making use of certain substances like alignments with the aligner or clear finisher, use of bleaching, with whitening the teeth, or sometimes use with seal trays, or it can even correct the incisal edges with minimal perforation, composite perforations, or it can do a retainedness, all those things. See, a good young girl, but broken teeth. Yeah. So you can see how the alignment of teeth are also here, same time. And you are giving a wire splint in back. Yes. And you can rebuild the whole story. Okay. And that's it. Here is a smile, dummy smile. Yeah. You can see how you have improved the dummy smile as well. Yeah. Teeth which have undergone periodontal therapy, but root are exposed. Not only root are exposed, but teeth are slightly mobile. So you do a splinting. Yeah. Here also you can see how the alignment of teeth is very poor occlusion, orthodontically damaged, completely collapsed. This is what it means. We use a multidisciplinary approach. You can see the gingiva, how dark it is, pigmented. You can improve the contour of the gingiva as well. Once again, yeah, here is a tooth broken. Okay, and you can replace it with the last structure and improve it in a proper way. Again, you can see how the teeth are colored, discolored. Yeah, broken also at another place. You can replace it with the natural teeth, and that's how it is. So depigmentation is also a very important procedure in periodontics, to improve the aesthetic aspect. Of course, lasers have come in the market, so I need not talk much on this. This is Ishikawa, who's supposed to be the father of laser therapy in the world, and you have got different ways. And this is the place where the 2001 bombing took place in New York. Okay, the whole thing was destroyed. Nearly 3,000 people died. Same thing happens in our mouth also. Everything is destroyed. Okay, damage takes place. The teeth goes haywire. Okay, and to reconstruct the whole story is a big effort. So the lady who was an assistant engineer in PWD came to me with all sorts of problems in alignment, periodontal breakdown, everything on the earth. So I had to do a real Herculean task to improve her aesthetics and all those things. But still she is having her natural teeth in the mouth, even after 20, 25 years of treatment. That is very important. Longevity of teeth, teeth for life. Okay. Again, he is a car driver having bruxism. You can see how his teeth have become flat. But his whole interest was you give me larger teeth. You make sure that my teeth are in one alignment. There should not be any gaps between the teeth. So ultimately, what is important is we have to reconstruct the whole aspect of the person. Make sure that we try to rebuild, improve the aesthetics, not only that, improve the periodontal tissues, reduce the microbial flora, the load of dangerous organisms, and make sure that we try to, improve the longevity of the natural teeth in the mouth. That is the whole story of periodontics, then giving a meticulous restoration. That's what Devon said in his lifetime, or it is a slogan of prosthodontics also. Okay, instead of giving a meticulous restoration, preserve what remains in the oral cavity. That was the whole summit of the talk. And that's my slogan as well, even today, after 45 years of my experience in periodontics and implantology. Thank you very much. This is P.D. Miller releasing my book.